Hello and welcome everyone. Today we'll be discussing about the research articles which have been published last week. The first study is to evaluate the impact of intraoperative hyperoxia versus normoxia on oxidative stress, kidney injury and other organ dysfunctions after cardiac surgery. The study design was an RCT conducted from April 2016 to October 2020 at a single tertiary care medical center. Participants 200 adult patients undergoing elective open cardiac surgery. The intervention is the patients were randomly assigned to either hyperoxia, that is 1 FiO2, or normoxia, that is the minimum FiO2 required to maintain a saturation of around 95 to 97. The main outcomes they were looking for were oxidative stress, which was assessed by measuring the F2 isoprostane and the isoflurane, AKI and other organ dysfunction as evaluated, additional outcomes like delirium, myocardial infarction, atrial fibrillation and other secondary outcomes. Participants were monitored for 1 year post-surgery. The results showed the oxidative stress was increased throughout the surgery in both groups. High levels of oxidative stress were observed in hyperoxia compared to normoxia. In terms of renal injury, no significant difference was seen. AKI occurred in 25% in both the groups. Other organ injuries, no significant difference in other organ injuries, including delirium, myocardial infarction, and atrial fibrillation. In terms of long-term outcome, intraoperative oxygen treatment did not affect the kidney, neuropsychological changes, functional outcomes at 1 year. So the conclusion is intraoperative hyperoxia increases oxidative stress but does not affect the post-op kidney injury or other organ dysfunction following the cardiac surgery. Strategies to maximize or minimize oxygenation during surgery may not actually influence the post-operative outcomes. So this is the study. 140 male, 60 female with a median age of 66, adult more than 18 years were used. This is one academic medical center in US, 100 in each group, and they found that similar outcomes throughout the period. So next is the efficacy of intubation blade and airtrack video laryngoscope for awake tracheal intubation in patients with anticipated difficult airway. There is uncertainty about the optimal video laryngoscopy for awake intubation in already anticipated difficult airway. The study compared the channeled airtrack and the unchanneled CMAC D-blade video laryngoscope. And the methods were, it was a RCT which was conducted in adults who were scheduled for elective or emergency surgery under general anesthesia. Patient required awake intubation due to anticipated difficult airway. The primary endpoint was first pass success of the intubation. Secondary outcomes were overall success, number of attempts, the view, the level of difficulty, patient discomfort and other complications. Coming to the results, 90 patients, mean age was 65. And they were randomly assigned into the two groups. First attempt success was higher with the CMAC blade, that is 84%, compared to the airtrack, which was 62%. The overall tracheal intubation success, no significant difference between the two groups. Difficulty and complication, no significant difference between the two groups. So in patients with anticipated difficult airway, the first attempt success was higher with the CMAC and no significant difference in other parameters. So coming to the next study, the efficacy and safety of early treatment with Gancamide in patients with aneurysmal subarachnoid hemorrhage, RCT. The objective was to evaluate the efficacy and safety of the drug in acute aneurysmal subarachnoid hemorrhage. The study design was the patient were randomized and the study period was from October 2021 to May 2023. Patients who had aneurysmal SH within 48 hours of onset were included. They were divided into two groups, that is intervention who received the drugs and a control group. The primary endpoints were the level of serum neuron-specific enolase, the level of soluble protein 100B, S100B. Secondary endpoints were changes in the midline shift, gray matter-white matter ratio, modified Rankin in the follow-up. Coming to the results, 111 patients completed the study. Median age was 55, 52 were female. No significant difference was observed between the intervention and the control group in the primary outcomes. CT scan indicated early bowel edema, but no significant difference in the midline shift or gray white matter difference. More than half of the patients had favorable outcomes with no significant difference between the two groups. The incidence of hypoglycemia was 4% in the intervention and 9% in the control group. So the conclusion is early treatment with Gancamide in aneurysmal SH did not reduce the biomarkers that we were checking. No improvement was observed in the neurological outcome. There was a trend for fewer cases of delayed cerebral ischemia in intervention group, but it was not statistically significant. The incidence of hypoglycemia was not significantly different. The next is low dose acute peritoneal dialysis versus acute intermittent dialysis for AKI. This was a RCT. It compared the efficacy of the two modalities. The RCT was done in Thailand from May 2018 to Jan 2021. 157 AKI patients, 800 in PD and 77 in HD group. The intervention was acute low dose PD, that was 18 to 24 liters per day, and intermittent HD 3 times a week. The outcomes they were looking for were 20-day mortality, which was in PD group 50%, in HD group 49.4%. Risk difference was 0.6, not statistically significant. 28-day dialysis-free survival was PD 41.8%, HD 37.1%. Risk difference is 4.6%. So the 7-day fluid balance again was in PD was 3 liters and in HD was 3,200 liters. 200 ml, and there was no significant difference between the two groups. So the conclusion is there was no significant difference between the parameters between the two groups. The results indicate that low dose PD is non-inferior to intermittent HD in terms of mortality, and this is the summary. RCT in Thailand, AKI 157 patients, and in terms of all the outcomes there was no significant difference. So acute peritoneal dialysis is not inferior to acute intermittent hemodialysis. The next is nasal high flow or NIV, navigating hypercapnia COPD exacerbation, and the study was to evaluate HFNO versus NIV in AE-COPD. It a multicentric randomized non-inferiority trial with 105 patients. The intervention was HFNO 51 and non-NIV 54. So the outcomes were treatment failure, that is 19.6% in HFNO and 14.8 in NIV, no significant difference. Patient comfort was slightly better with the HFNO compared to NIV. The respiratory parameters, both groups showed similar changes, but there was no significant difference. And respiratory parameters again had no other difference. So the conclusion is HFNO is non-inferior to NIV in patients who are having acute exacerbation of COPD. It may be preferable for patients who have comfort issues. So this is the summary: 51 patient, 54 patient, treatment failure, 10 patients, 8 patients, and patient comfort was statistically better with HFNO. So we may use it for patient comfort. Respiratory parameters are similar. Now, final study is automatic mechanical ventilation versus manual bag ventilation in CPR to assess the whether the automatic mechanical ventilation is feasible and versus bag mask in out-of-hospital cardiac arrest. It is a pilot RCT with 60 patients, and the intervention was automatic mechanical ventilation 30 versus bag mask in 30. The outcomes they were looking for were primary outcome was return of spontaneous circulation, which was in mechanical ventilation 56, bag mask 43, no significant difference. Secondary outcomes, arterial blood gas, no significant difference. Tidal volume was significantly lower in minute ventilation. Minute volume was lower in minute ventilation. And the conclusion was that the use of mechanical ventilation is feasible and serve as a viable alternative to bag mask. While tidal volumes were lower, ROC rates and arterial blood gas changes were similar between the two groups. A large multicentric RCT is recommended based on this pilot trial. So this is the summary. This has been published in CHEST. So this is automatic versus manual, 56.7 in mechanical ventilation, 43.3 ROC in bag mask. This is the tidal volume changes, which was significantly lower with the mechanical ventilation, but then the respiratory parameters were similar. Thank you for your patience.